Greetings. Today we are going to talk on videolaryngoscopic basic one. So, if you look in the market, there are different varieties of videolaryngoscope and they are differ in their design. So that creates a confusion. Which one to use, which one to buy, how to use it, how to optimize success rate. So we are going to discuss a videolaryngoscopy basic. So today we are going to understand geometry of videolaryngoscopy, means from different curves with clarity. Look at this video. Here I am using a non-channel videolaryngoscope, and it's very easy to use. Tube is easily going. On another video, same the channel videolaryngoscope, but tube is impinging on the epiglottis. Let's look at the third video. Here, using the non-channel videolaryngoscope for nasotechnical intubation, but tube is sliding to the surface. So how to overcome this problem? For that, we need to understand the design and manipulation to be done in a videolaryngoscopic intubation. So we are going to address certain questions like how to improve success rate, which position to be used for videolaryngoscopy, whether it's a sniffing, neutral, or RAM position. Which one to buy? There are a number of videolaryngoscopes. Which one to buy? Macintosh type, Angulated, hyperangulated. So there are different type of videolaryngoscope with the different curves. So that needs clarity. So first we have to understand what is videolaryngoscope. So nowadays compact, high resolution, micro video camera are available, which is to be embedded a few centimeter proximal to tip of laryngoscopic plate, which convert that into a video laryngoscope. But whether this serve the purpose or not, for that we need to understand how video laryngoscope works. So any video laryngoscopic intubation is having three components. First, we have to expose the larynx. Second, we have to make entry into the larynx. And third, passage of the endotracheal tube. Before going into detail, let's discuss the few basics. So each camera is having its perimetry, like our perimetry of our eye. That's called viewing angle of that camera. And that at distance what video camera visualizing the structure up to the distance, that's called the depth of field. So when we are using a direct laryngoscope, so direct laryngoscope is like a going on a straight road. You can see the far vision by creating a direct line of sight from eye to the larynx. But it's not true for video laryngoscope. So for video laryngoscope, you have to travel through a curvy road. Let's understand this. So suppose this is a curvy mountain road, and this is your target. Fine. So it's having two curves. One that is primary curve, and second that is a secondary curve. So the line joining the primary curve and secondary curve is this yellow line, and which is relatively straight. So this yellow line joins the two curve, primary curve and secondary curve, and that's the basic. Fine. So if you're traveling a car from here, so and this is the target, you'll not able to see the target until you reach at the proximal end of the line. Fine. From here, you can see the target. Now, if you are driving a car, whether you are here, whether you are here, whether you are here, or whether you are able to see the target. Wherever on this straight line, you will be able to see the target. So once you reach the target, then you have to turn down. You have to turn down. So this practically applies to video laryngoscopy, two curve theory that has been given by Dr. Greenland. And according to this theory, there are two curves of upper airway. Primary curve, that is oropharyngeal laryngeal curve, and secondary curve is pharyngeal laryngeal tracheal curve. And this is the larynx, that is our target. So, the primary curve and secondary curve joined by a straight line as we discussed in the curvy mountain road. And if we are able to place a camera over this line, and if that camera is faced towards the larynx, we will get the laryngeal view. That's the simple basics about the videolaryngoscopy. So you have to place a camera over this line, and that camera should be focused towards the larynx. Now, this is glottic aperture. Fine. So in short, when we are doing direct laryngoscopy, we are seeing from our eye to larynx directly by compressing the tongue and shifting the soft tissue above the line of sight. But in a videolaryngoscopy, it's simple. We are shifting our eyesight into the pharynx to take the image of larynx. So line of vision with the videolaryngoscope is only this much, this yellow line. And because of this only this short line of vision, it eliminates the need of tissue compression and 3-axial alignment. In short, videolaryngoscope enables us to look beyond the curve of tongue. And as it looks beyond the curve of tongue, it provides a better glottic visualization by eliminating the need of oropharyngeal laryngeal axial alignment and tissue compression. Let's discuss the different curvature of the videolaryngoscope. So if you take the AirTrack, J-angulated videolaryngoscope, AirTrack or King Vision. So curve of when this videolaryngoscope is C2, if you look at the curve, this curve matches with the oropharyngeal laryngeal, means the primary curve. That's why it's called anatomically curved blade. So when you are using the CMAC-D blade or gyroscope hyperangulated blade, where is C2, it matches with the oropharyngeal laryngeal, means primary curve. Again, that's the reason it's called the anatomically curved blade. But when you are using the macintosh type of videolaryngoscope, it's not matched with the primary curve of oropharynx. So that's why it's called the non-anatomically curved blade, or we can call it as a macintosh type of blade. So simple sense, if you want to classify the videolaryngoscope, it can be classified into anatomically curved blade, which is J-angulated and hyperangulated, and non-anatomically curved blade, that is macintosh type of blade. And in an anatomically curved J-angulated blade, there is a channel 1 and non-channel 1. So let's look at the position of camera of videolaryngoscope. What's having a clinical impact? It's having a clinical impact on the laryngeal view, force of laryngoscopy, and manipulation to be done to get the tube in and to get the better view. So if you look at this two type of devices having more than 90-degree angle, while this is having almost 90-degree angle. What does it make difference in our clinical practice? Let's look at. Suppose we are taking a J-shaped videolaryngoscope, like King Vision or AirTrack or Pentax. So when it's C2, the camera takes the position on the proximal part of the line joining the primary curve and secondary curve. And so it's looking from far from the larynx. And that's the reason we get the panoramic view. So that's the advantage of using this type of blade, because camera takes the position on the proximal part of the line joining the primary and secondary curve, and it's looking at the larynx much far from the laryngeal area, and that's the reason it gets the panoramic view. But when you are using the hyperangulated blade, camera takes the position on most the steeper part of the line joining the primary curve and secondary curve. So it's looking just near, just in front of the larynx, and that's the reason you get good pogo scoring, good Cormick and Lehan grade, because it's just looking at the larynx just in front of the larynx, because camera is placed on the most deeper part of the line joining the primary curve and secondary curve. But when you are using the Macintosh type of videolaryngoscope, again, when you are using Macintosh type of videolaryngoscope, you need to shift and compress the tongue to get the view. So these are the difference between the different type of videolaryngoscope for the laryngeal view. Let's again look at the J-shape angulated videolaryngoscope. King Vision, AirTrack, Pentax. So when it's in situ, the camera takes the position here, most proximal part of line joining the primary curve and secondary curve, and it's looking straight. So that's the reason many times you are not getting the complete laryngeal. You will be able to see the only posterior part of the larynx. So to get the complete view, you have to lift up the scope bit earlier. So when you are using this J-shape angulated videolaryngoscope, little bit of force is required, and epiglottis can block the view. So with this type of videolaryngoscope, it requires bit force. Epiglottis can block the view, and little force of laryngoscopy is required. So when you are using the hyperangulated blade, as discussed, the camera takes the position on the most deeper part of the line joining the primary curve and secondary curve, and it's looking just in front of the, looking at the larynx, but just in front of the larynx. That's the reason you get the good pogo scoring. So minimum force is required. Look, so camera is here, looking at the larynx, and look at the tongue is lying on the blade. So minimal force is required. You get a good pogo scoring, good Cormick and Lehan. So now, difference between the anatomically curved blade and Macintosh type of blade. When you are using or direct laryngoscopy and indirect laryngoscopy, when you are using the indirect anatomically curved blade, you are looking at the larynx from down to up, from pharynx to larynx, from down to up. But when you are using direct laryngoscopy, you are looking from outside the eye, from this area, eye to larynx, that is from upside down. And when you are using the Macintosh type of videolaryngoscope, still you have to give the force to get the laryngeal view. And epiglottis can block the view. But when you are using this hyperangulated blade, because it's looking from down to up, epiglottis rarely block the view in anatomically curved hyperangulated blade. But when you are using the Macintosh type of blade, epiglottis can block the view. So now look at we'll discuss the angulation and clinical impact on insertion. So if you look at this J-shape angulation, if you look at the width of this tip to this curvature is bit higher, and that creates little bit of insertion difficulty. And when you are using the hyperangulated blade, because from tip to curve is wider area, that again creates a bit higher difficulty on inserting the two, and that's the reason it has to be inserted into the midline, parallel to hard palate, soft palate, and as the path of the oropharyngeal curve. So it's easy to insert a Macintosh type of videolaryngoscope. So now we'll discuss the viewing angle of videolaryngoscopy and its clinical impact. Look, so there are different type of angle of the camera. What is angle of the viewing angle of the camera? So our eye is having our own perimetry. Beyond our perimetry, we can't see. If you want to look at beyond our perimetry, we have to move our head towards the area to be looked upon. Same way, all videolaryngoscope is having its own perimetry. That's called viewing angle of that camera. So few videolaryngoscope is having a narrow angle camera which is less than 65 or around 65. So when you are using the narrow angle camera, And when you place the camera in front of the object, you're not able to see complete view of object because it's having a narrow angle. So to get the complete view of the object, what we have to do, you have to withdraw the camera and then look at the object, then we'll be able to see the complete object. And that's the reason when you're using the narrow angle camera, many times narrow angle video laryngoscopic camera, you have to withdraw the video laryngoscope to get the complete laryngeal view. So withdrawal is required in such type of devices. Now, suppose you are using wide angle camera. Wide angle camera is more than 75 degrees. So in spite of having less distance of camera from the object or from the larynx, you will get a complete laryngeal view because its viewing angle is wide. So what is the clinical impact of this? So this is, suppose this is narrow angle camera, this is wide angle camera. So what is the clinical impact? Look at this. With the narrow angle camera, you get a good pogo scoring, but you will not able to see the adjacent structure. While in a wide angle camera, we'll be able to see the larynx completely along with the adjacent structure. So when you are looking at the adjacent structure, it decreases the chances of trauma. You'll get the visualization of tip earlier you can easily manipulate the tube towards the larynx. So that's the advantage of using wide angle camera. So when you're using wide angle camera, it increases the ease of insertion of the scope with the less trauma. It increases the ease of insertion of the tube, and it's easy to manipulate the tube because you are able to visualize the tip on the camera vision. So that's about the laryngeal view and curvature of the videolaryngoscopy. So now, and laryngeal exposure. Now we are coming to the second part of the videolaryngoscopic intubation, that is getting entry into the larynx and passage of the endotracheal tube. So that will be on videolaryngoscopy session 2. Stay tuned to join us on this channel for session 2, which is coming by next week. Thank you.